My name is Alyssa, and this is my presentation on fluid resuscitation in sepsis. So for my PICO question, I went with, in adult patients with suspected or confirmed sepsis, would early implementation of fluid resuscitation result in improvement of hypotension, tachycardia, and organ perfusion within 5 hours? For a little bit of background, I work in the emergency department and we see sepsis patients all the time. And usually the treatment that we will initiate in the emergency department is fairly similar across the board. We will give them, fluid boluses, implement antibiotics right away, draw lab work, and kind of monitor the patient until we get lab results back, and then we will kind of go from there of how we will treat it depending on what the lab work shows. For my research that I conducted for this project, I looked at 3 different studies, most of which were retrospective cohort studies. One was conducted with the Department of Emergency Medicine at the University of Wisconsin. The second one was conducted with the Department of Medicine, specifically the Division of Allergy, Pulmonary, and Critical Care Medicine at Vanderbilt University. And the third was conducted with the Department of Medicine at Mayo Clinic. The patients used for these studies were confirmed and identified based on ICD-9 and ICD-10 codes, which are diagnostic codes, and specifically patients over the age of 18, as to avoid any other factors that could misconstrue the results with pediatric patients. There were some limitations that were identified with these studies specifically, one of which was a limited sample size in one of the studies. One of the studies was conducted in a more rural part of the country at a more rural hospital that has less foot traffic than, vice versa with another study that I researched that was conducted with a very large trauma center that has a lot more foot traffic and a lot more patients coming through the hospital. Another limitation was documentation discrepancies. Sometimes it was noted that nurses did not document the proper stop time for the fluid boluses. And then the other limitation that was noted were facility limitations as well. So this situation is pretty important because, as I had mentioned previously, I work in the emergency department. So sepsis patients are very common to us. We see them a lot. And when we have a patient come in that we are suspecting sepsis or septic shock, we don't wait to get lab results. We will immediately start treating them for sepsis right away because it's very time sensitive. And for decades, the fluid of choice for fluid resuscitation has been 0.9% normal saline, a crystalloid solution. And that was due to its low cost, it was very readily available, widespread across the country, and it's very commonly used. However, as time has gone on and researchers have noticed that more and more patients were starting to have more poor outcomes with sepsis and complications that were coming up later on in the hospital stay, they started to do a little bit more research around fluid resuscitation. And the question was coming up because, as I had mentioned, 0.9% normal saline was the fluid of choice for fluid resuscitation. However, the composition of normal saline is more acidic than the blood plasma of a person. Normal saline is about 5 on the pH scale, and your blood should be between 7.35 and 7.45 on that pH scale. And the chloride content of normal saline is over 40% more than plasma. And so they have noticed that complications were coming up later on in the disease process due to fluid volume overload from heavy fluid resuscitation in the beginning stages of sepsis, and it was causing more complications later on down the road. And so the question then came up that, what type and amount of fluid will help the symptoms of sepsis and septic shock, such as hypotension, without causing additional complications, but also still achieving better outcomes for that patient, like maintaining organ perfusion. So throughout my research, some findings have shown across the board in favor of the use of crystalloid solutions such as 0.9% normal saline. And studies have also shown that early implementation of 1 to 2 liter boluses to regain that organ perfusion, then after that, we can look at additional options for maintaining perfusion that does not include the use of crystalloid solutions, such as vasopressors, for example, are a common one that we can use as well. And the idea of implementing the dosing of fluids based on patient responsiveness rather than just a set protocol. For example, we have a patient come in who is pretty hypotensive and we're suspecting septic shock or sepsis, and we're going to give them a liter bolus of fluids. After the bolus, we retake their blood pressure and it has come back up 120/80, and that's considered a normal blood pressure. Well, instead of giving additional fluids, maybe we hold off on giving more fluids since now their blood pressure is back to normal. We'll just monitor it really closely, and if they can maintain that blood pressure, then we don't need to give additional fluids at that point in time. Whereas another patient might come in with a very low blood pressure, we give them a liter bolus of fluid, their blood pressure has not come up at all, maybe a couple points systolically. And so we may consider giving another bolus of fluids to help bring that pressure up again. Now we give them a second bolus of fluids. Well, now their blood pressure is back up to normal. That's great. Now we may consider not giving them additional fluids at that point in time. So the idea behind basing the dose of fluids on patient responsiveness rather than just a set protocol amount that says in every sepsis patient we give them 2 liter boluses, but basing it off patient responsiveness, we look at the patient, we look at their vital signs, we look at how they respond to that initial bolus of fluid, and we go off of that. If they need more, we'll give them more. Otherwise, if they don't, we'll hold off. That way we can avoid overloading that patient with fluids that they don't necessarily need. To go off of patient safety and quality of care, if we have a patient come in with sepsis or septic shock, obviously one of the number one priorities with that patient is to maintain organ perfusion. We want to maintain perfusion to the brain and other organs, and so if we can dose our fluids accordingly and maintaining organ perfusion, we can try to avoid overloading that patient by, again, dosing our fluids based on patient responsiveness rather than just a set protocol. It's better for the patient by not having an excess amount of fluid, and also we can avoid complications later down the road that would encourage, a longer hospital stay when we could potentially get that patient out, a few days sooner if we can avoid those other complications associated with it. So the plan that I want to implement in this scenario is if a patient arrives to the emergency department with symptoms of sepsis or septic shock, such as hypotension, tachycardia, fever, etc., we would immediately begin a 1 liter bolus of normal saline. And from there, we will continue to monitor those patients' vital signs and other symptoms that we notice of septic shock and sepsis. And if their blood pressure is stable, we're going to withhold additional fluids until lab results have come back. Once we get lab results back, we can dose additional fluids based on those lab results if the patient shows that they need it. And also, we'll look at patient symptoms, their vital signs, etc., as well as in the process identifying source of infection if possible and treating the infection as well. To evaluate the effectiveness of this plan, we would monitor serial lactic acid levels to make sure that the lactic acid in the blood stays at a very minimal amount. We'll monitor kidney function as we are going to be giving this patient a lot of fluid. We want to make sure that the body and the kidneys can handle this amount of fluid without causing additional damage and creating a second problem in the scenario. And we'd also monitor other lab tests as well. And vital signs, if the patient starts becoming hypotensive, maybe we give them additional fluids, or depending on their kidney function, if they have elevated creatinine and BUN, maybe we need to look at other medication options such as vasopressors. But ultimately, we're looking for the best patient outcomes without causing additional complications. So thank you for considering this research plan, and I appreciate your attentiveness.